evening, everyone, and welcome to DeBakey CV Live. Today, I'm joined by my good friend and colleague, Dr. Bavare. I'm Tom MacGillivray. We're from the Department of Cardiovascular Surgery here at Methodist in Houston, and we're going to be talking about pulmonary embolism and all that entails. So a couple of housekeeping items to start with. I don't know, Charu, unfortunately, I don't have any financial conflicts. I don't think you do either.
I'm in the same good boat as you are.
Yeah, I don't know if it's good or bad, but we're certainly willing if anybody has any offers. So this is meant to be an interactive session about pulmonary embolism, and so we would encourage all of you watching to participate, and you can connect with us at polev.com/DeBakey, and if you have questions, and I hope you do, you can, through texting, you can text 37607, and with that, in the text box, please type DeBakey, and then you can text in your questions, and we'll be taking them as they come. So as I said, the topic for today is pulmonary embolism, and this is a portrait of one of my mentors when I was in medical school, Dr. Judah Folkman. He was a world-famous pediatric heart surgeon, at least at the time, the youngest professor of surgery at Harvard Medical School. And many would say he was well on the way to winning the Nobel Prize. While getting off of an airplane at the Denver airport, he suddenly collapsed and dropped dead of a pulmonary embolism. I would like to say that that's a rare and unusual event, but Charu, as you know, it's a very common thing. The incidence of pulmonary emboli are about 600,000 a year, 600,000 a year. And it accounts for about 50,000 to 200,000 deaths a year as well. It's the third leading cause of death, and it accounts for about 15% of hospital deaths per year. So the International Cooperative Pulmonary Embolism Registry is interesting. You know, when I was in medical school, Charu, people got pulmonary emboli, and either they survived or they died. Mm-hmm. And certainly it was hard to know when somebody had a PE whether they were going to be one of the ones that died from it or whether they were going to survive it. And I think one of the benefits of this study that was published in the late 1990s was that it showed that people who die from pulmonary emboli don't necessarily die suddenly right away, that even those people who die over a period of 6, 8, 12, or 48 hours later. And I think one of the benefits of this study, they showed that those people who die, one of the things that they have in common are they're hypotensive. Mm-hmm. And they don't have to be completely hypotensive consistently. They can have a period of hypotension. And the second thing that was of value, at least for trying to strategize and stratify them, was that on echo, those patients who were going to die were more likely to have significant right ventricular dysfunction.
You know, and Tom, interestingly, this also leads to, that is a consistent finding even today, is hypotension and right ventricular dysfunction still remains the top two leading predictors of short-term and long-term mortality. Is that correct?
Right. Correct. That's my understanding. So I think that that those are two very important things to look for, and if you see them, those are patients that require. All patients require a lot of attention, but those are the patients who require extra attention.
Of course.
And we're going to focus most of the hour on pulmonary embolism, but it's important again to point out that just because you're hypotensive or you have right ventricular dysfunction doesn't mean that you have a pulmonary embolism. The differential diagnosis are certainly probably in rank order, not necessarily in rank order, would be an acute coronary syndrome. Somebody having a myocardial infarction, coming with chest pain, shortness of breath, hypotension, and you could see right ventricular dysfunction.
Right.
Tamponade, aortic dissections, someone that has valvular heart disease and valvular dysfunction, patient with hypovolemia. So, Char, what would you say is the best way to quickly evaluate and exclude those and include pulmonary embolism? What's the recommendation for working it up?
I still think a good history is important to know how this started and what were the pre-existing comorbidities which might have led to this. Any history of an old DVT or PE should trigger the diagnosis of a recurrent DVT or PE. But again, I was always taught not every hypotension or chest pain is PE, and the other way around, not every PE comes with chest pain and hypotension. So we do miss some. At the same time, we have a tendency to overdiagnose. But again, the condition that you mentioned, the acute coronary syndrome, cardiac tamponade, they are lethal conditions if not treated quickly. So going back to your question about a good history, a good physical exam, and then of course imaging comes right after. With today's availability and accessibility to good EKGs, CT scans, lab tests, echoes, I think the diagnosis can be narrowed down pretty quickly. Don't you think so?
Sure. So history, physical, vital signs.
Of course. Sorry.
Vital signs of vital signs. Yes. And then, I mean, I really take my hat off to emergency room physicians, because it's very easy for we specialists to sometimes once we have the benefit of the diagnosis, it's easy to be a Monday morning quarterback to say, oh, you should have done this, you should have done that. They really do a terrific job at very quickly going through this differential diagnosis and coming up with the diagnosis. So what in your opinion, what's the kind of the go-to imaging study to sort this out?
So I think an initial assessment of hemodynamic stability and then triaging them. But if someone is hemodynamically stable and a diagnosis of PE is suspected, I think a CT angiogram would be the fastest, easiest, and most definitive test in today's day and age.
Right. So certainly, if you look at our Epic and you order a chest CT, you have to choose from a menu of a lot of different things. So what kind of CT should we specifically order, Charu?
So it's a CT angiogram, which is a specific CT with a little higher dose of contrast and specific cuts made for the pulmonary artery. A CT angiogram with a PE protocol, and that's the right exam. It's essentially, for the lame person, a CT scan would mean a CAT scan of the chest, but with contrast, what phase to use, which part of the artery and vein to accentuate or opacify on the CT. There are certain protocols that are set in radiology, and the order sets are linked to those protocols. And so I think you're absolutely right, Tom. Ordering the right test is critical. Putting in the right words for the right test is also critical. But almost universally, a CT angiogram with a PE protocol would get us to the diagnosis of a PE, or exclude the diagnosis of PE.
And things that we look for, and we've got some illustrative CTs on the screen. So, of course, this is the classic saddle pulmonary embolism, where you have a clot, a thrombus that is traversing the pulmonary artery bifurcation. In the middle, we have more peripheral PEs, and although saddle PEs carry all the glitter, all the concern, you can have a very hemodynamically significant pulmonary embolism from peripheral PEs. And you may, if you looked at that without looking at it carefully, you could potentially miss it if you were just looking at the central PEs, central pulmonary arteries. Another very important point in the algorithm of diagnosing and trying to stratify is looking at the ratio between the size of the right ventricle to the left ventricle.
So before you tell me, normally for the person listening to our web live, what should it be? Is the right ventricle bigger or smaller, and why is it?
Yeah, so the right ventricle is usually much smaller. It's about half the size, half of the diameter of the left ventricle. It kind of drapes itself, the right ventricle drapes itself over the left ventricle. So if you get more than 60%, if you get more than 60% right ventricular size to the left ventricular size, that's starting to become abnormally large. And once you get above certainly 1 to 1, or the purists would say 0.9 to 1, that's an abnormally dilated right ventricle. And that should, I think, perk up your eyes and your ears and all of your senses that this may be not only just a pulmonary embolism, but a hemodynamically significant pulmonary embolism.
And then we have a question. Shall we take a question here?
Sure, yeah.
So they say, can you have a PE without DVT? So I think, and I can take this question, almost extremely uncommon. I think almost all the PEs that we see are embolic, and that's why it's called pulmonary embolism. If there is a de novo clot in the pulmonary artery, it would be pulmonary thrombosis. So I think more than 95 or more percentage of PE is always not in the pulmonary artery but comes from somewhere.
Right. And I guess the flip side is, and if you want to talk about zebras, once every couple of years we make the diagnosis of a pulmonary artery sarcoma that looks like a pulmonary embolism in somebody that doesn't have a DVT.
Wow.
And it turns out to be a sarcoma, but that's a topic for a different webcast.
That's right.
So in addition to the CTA, echo is also a very good way to assess for right ventricular dysfunction, and certainly in most emergency rooms and ICUs is readily available. And in the hands of someone with some experience, you can get a very good assessment of not just the size, the ratio of the right ventricle to the left ventricle, but also other signs, whether there's tricuspid regurgitation. You can get an estimate for what the right ventricular pressure is, and whether there's tricuspid regurgitation.
And on the echo, correct me if I'm wrong, the hard part is saying whether it's mild or moderate dysfunction. I think there's a clear cut, we know for sure either it's normal or it's really bad.
Right.
The one in the middle is where the problem lies, where there is there could be a difference in who's reading it, there's a difference in how it's acquired. Is that correct?
That is correct. I mean, one of the good things, one of the many good things about an echo, it's readily available, it's non-invasive, but it is dependent upon the size and the body morphology of the patient. The windows can interfere with sometimes the images that you get, and of course it needs to be interpreted, and so those are the downsides to getting an echo.
So if we have a normal right ventricular echo versus a severely depressed echo, those are black and white, so to speak.
Right.
So it's pretty dependable, correct?
I would say that's pretty dependable.
Yes.
Correct. So as I mentioned earlier, not all pulmonary emboli are the same. Mm-hmm. We have learned over the years since that international cooperative study how to stratify them in terms of risk. You want to talk about that a little bit?
Yeah, sure. So, it's not just the PE, but how the PE manifests clinically in that patient determines how the PE gets treated. And, Tom, you mentioned, or you showed the slide of a big saddle PE. For example, I had a patient earlier in training where we had a big saddle PE, but completely normal hemodynamics.
Right.
And in those patients, then we don't treat the image, we treat the patient as is classically told. To risk stratify them as to what kind of PE, there are broadly three types of classification. One is a massive PE, where there is a PE, for sure, that's diagnosed on a CT angiogram, and then you have hypotension, which is a systolic blood pressure less than 90 millimeters, it doesn't have to be sustained. It could be at least a 15 to 20 minute episode, and they could be normotensive after that. But that initial hypotension is the trigger to massive PE. There should not be any other reasons for hypotension, for example, sepsis or some kind of a hemorrhagic or neurologic shock or some arrhythmia of the heart. It should be purely because of the PE.
And I think the point you just made is a really important one. If somebody's hypotensive for 15 minutes and then they get better, it's reassuring that the hypotension is better, but they're still in the high risk group.
Of course.
That's a
great point.
It's better that they are not hypotensive anymore. It's better that they're not more hypotensive, but it doesn't mean that you can pat yourself on the back and walk away.
Right. Absolutely. The second one is the submassive PE, which is typically what we see more commonly, where there is a PE which is diagnosed on CT angiogram, but the blood pressure is normal. They do not have any hypotension, but they have some clinical signs or lab signs or imaging signs of some myocardial strain. I keep telling my patients that imagine a PE is a 6-lane freeway going into a 2-lane freeway going into a dead stop on a clot. So imagine the amount of backup on the right ventricle that it has to face. And so the ventricle gets strained, the heart muscle gets strained, so you see an increase in the troponin level. You will see the RV, or the right ventricle to the left ventricular ratio of more than 0.9, which is the number to go by, or an increase in the beta-natriuretic peptide numbers. So if you see any of that, that becomes a submassive PE. And those will trigger a further thought process of maybe these people need some more intervention than just anticoagulation.
So not every elevation in troponin is an acute coronary syndrome.
Yes.
So if you have someone with the history and the physical findings of a pulmonary embolism, a dilated right ventricle that's hypokinetic, and an elevated troponin, don't switch your thinking to, oh, you need to go to the cath lab because this is a coronary event. That's all consistent with a submassive pulmonary embolism.
Very true, very true. And then the last one is the low risk PE, which is probably the majority of the PE that we see and sometimes miss, is the ones who are normotensive, who are normal biomarkers, who are not strained by lab numbers or on echocardiogram. And those are the ones that when we diagnose them, we don't think about interventions, we think about anticoagulation only.
Right. And part of the triage too is that if somebody's had a pulmonary embolism, the concern is that they're at risk of another subsequent pulmonary embolism within that same period of time or same hospitalization. So it may be that they have managed to not get critically ill from that pulmonary embolism, but they will be susceptible to another subsequent one from perhaps the same thrombus burden.
Absolutely, and not just immediately, and you're absolutely right, the initial risk is immediately within 30 days, but they have about a 6-month 15% and a 5-year, I think about more than 40% chance of having another DVT PE subsequent to the first one.
So we have a great question.
Yes.
That's a practical question that was asked. What can I do to reduce my chance of having a DVT after a long plane journey?
So that is a great question, because this applies to the general population at large. I just think that number one, the most important thing to remember is, are you at risk of having a DVT? Period. Number one is, do you have a history of DVT in the past? Number one. Do you have a family history of DVT? That puts you at a higher risk for having a DVT, not just on a plane journey, but more so on a long plane journey. Our recommendation typically is don't stay immobile for too long. Remain hydrated. Get up every 2 to 3 hours at a minimum. Stretch. They have airlines have these exercises that they've mentioned. I think all of that is fair game. The key is to stay hydrated. The key is to stay mobile, and the bigger thing to remember is, are you at a risk to begin with?
Risk factors, yeah. So
Risk factors.
and those risk factors would be if you've had a clotting problem in the past.
Yes.
If you've had a DVT in the past.
Yes.
If you've had a stroke or any other potentially clot-related.
Yes. And a strong
problem.
family history. If
Strong family history.
many immediate family members have had diagnosed hypercoagulable or high risk state. Yes.
So since you're on a roll, Charu, so the breakdown of percentage of how many pulmonary emboli are massive or high risk, how many are intermediate or submassive, how many are low risk.
So
Okay.
as a graph, Tom has put this together really nicely. So as you can see, the most uncommon one are the massive PE or the unstable patients, but if you see the total number of the mortality is the highest in those people. So as we pointed out earlier, somebody with hypotension who's normotensive is not outside the danger zone. They are still at risk for mortality. The middle portion is about more than half is where they are hemodynamically stable, and they have some biomarkers or echocardiogram findings of strain, and then their mortality is about 3 to 10 or 2 to 5. And then the lowest risk mortality is the ones who are stable and who have almost normal biomarkers, etc.
So based on the risk, that will determine how these patients should be managed. And we have a lot of clubs in our bag, if you will, how to manage patients with pulmonary emboli. And that initial risk assessment is very important. It'll help us determine which pathway we go down. And we'll talk about these in a little bit greater detail, but somebody that's suspected of having a pulmonary embolism, as soon as you suspect somebody might have a pulmonary embolism, what should you do, Charu?
So the first thing is to get them anticoagulated, unless they have an absolute...
Could you say that one more time?
Yes. So the first step is to get them anticoagulated and effectively anticoagulated. That is the key. And unless they have an absolute contraindication or a fact or something that prevents them from getting anticoagulation or blood thinners, they should be getting their dose if we have a high suspicion or a proven diagnosis. Even a high suspicion of PE is fair game to give them the first dose of anticoagulation.
Right. And so while you're evaluating them, if you have a high index of suspicion, anticoagulate.
Yes.
So in patients who have a massive pulmonary embolism, somebody's hypotensive, and you think they have a pulmonary embolism, what would you recommend?
I would still say give them their first dose of anticoagulation.
Right. And then you go down and get a CT or an echo looking to make that diagnosis.
And Tom, to your point, we just mentioned the fear or the concern in the first responder or the first person who sees a PE is this dose of anticoagulation going to make the interventionalist task difficult or the surgeon's task difficult? And it's not. I mean, we've seen that a few hours past the low dose of Lovenox or the dose of the heparin that they've been given, I would prefer Lovenox, and we'll come to that in a few.
Yeah.
But the first dose of anticoagulation doesn't adversely affect them unless they're having brain surgery for some other reason. And so I think the myth of not giving blood thinners initially should be dispelled as much as we can.
So in patients who are at high risk, the recommendation is the first drug you should give them is unfractionated heparin. And I think in my experience, people err usually on the side of too low of a dose rather than too high of a dose.
True.
And that the goal of that heparinization isn't to dissolve the clot. The heparin does more than just anticoagulate. There's all kinds of other good things that we might not totally understand that seem to be of benefit from heparin. So the recommendation is to give a bolus of 80 units per kilogram of heparin, followed by an infusion of 18 units per kilogram of heparin. And that you can, and the goal is to get them as therapeutic as quickly as you can. So what if somebody's persistently hypotensive? Somebody's got a blood pressure, systolic blood pressure of 60, and you've made the diagnosis by CTA, that they have a massive pulmonary embolism, which saddle pulmonary embolism.
So I think that should then trigger the consult for if you have a shock team, or if you should have ECMO support available if you can. And I think that should then prompt that phone call to the ECMO team. This patient probably needs to go on some form of support, and as a bridge to getting a definitive treatment for pulmonary embolectomy, or go straight to the operating room if they can be transported that way.
What about so I think that what about systemic thrombolysis? What's the conventional wisdom, and what's your thought about systemic thrombolysis for massive pulmonary embolism?
I think we were talking about this earlier. We are surprised that it works, and we are not surprised that it sometimes doesn't work. But I think it's a great tool to have, no doubt about that. Again, systemic thrombolysis does not hurt us a few hours down the line, but it does hurt us immediately if the patient needs to be operated on. I think if a patient does not have any absolute contraindications for thrombolysis, if they're hypotensive and they are not able to be transported, probably this is fair game to try systemic thrombolysis in such patients.
So I think in the real world, in most emergency departments, I think on the hospital wards and in the intensive care units, probably what would be considered the standard of care right now in somebody who's hypotensive and hemodynamically unstable with a massive pulmonary embolism, they'll probably, and probably should, I think, unless there's something else immediately available, and we'll talk about those things, get systemic thrombolysis. And we have a question about the options of management of a submassive or massive pulmonary embolism in someone that's actively bleeding. So that would be an absolute contraindication.
Correct.
For a systemic thrombolysis, and we've got listed some of the other absolute and relative contraindications. I think probably the biggest is somebody that has had a recent hemorrhagic stroke or a stroke of unknown origin. Interestingly, I find this one, somebody who's had an ischemic stroke in the last 6 months. That seems to be, I would have found that to be kind of interesting.
I think it's more fear-driven than evidence-driven, maybe.
Right.
It's more precautionary than anything else. But on the question of what to do for the patient who's actively bleeding with a PE or a submassive PE, I think that is also, we said that's an absolute contraindication for thrombolysis, but it makes an absolute indication for an IVC filter in these people. Right. Because you want to prevent a second hit because you're not able to anticoagulate or lyse these people.
So one of the questions that is that's been brought up, and we're going to get to this towards the end of the program, is the role of a PERT team. And I think that as common as pulmonary emboli are, as frequent as they occur in patients who are otherwise ill from other problems or sick from other problems, I think that most big centers around the country and around the world have found the benefit of having a PERT team, having experts in different disciplines who can be immediately available to help strategize how to take care of individual patients that have specific indications and contraindications to the different therapies that we have available. So and we will get into in patients who are having a massive or a submassive pulmonary embolism what some of the other options are, and that would be probably some catheter-directed therapy or surgical embolectomy, or somebody who's, I think, imminently going to arrest. Probably the thing to do then would be to put them on VA ECMO, but we'll get to that momentarily. This is Charu's favorite slide. He loves the severity index scores. You want to talk about that? Just kidding about that, but.
I was going to say favorite from the other end of my spectrum is the lowest favorite. So I mean the PESI score, or the PESE as we call it. This actually stratifies patients based on their comorbidities, based on their present findings, biochemical findings, But this is not something that should drive their immediate treatment. This will give us an idea of what they're going to do 30 days or 60 days or many years from now. It's a good score to have it in our backpack, but not to bring it out as our first card, for sure.
Right. So back to systemic fibrinolysis. It's pretty interesting. I think that if you look at, again, for patients who have a massive pulmonary embolism that are hemodynamically unstable, in the real world, most of those patients should get, and the recommendation is they should get systemic thrombolysis unless they have a contraindication to it. For patients who are at intermediate to high risk, or the submassive pulmonary embolism, as we were talking about earlier, I think many people still reach for it, but I'm not quite so sure that they should be reaching for it. The data about it, the benefits, are not, and we'll get into that briefly in a second, the benefits aren't that great, and certainly the risks can be high. I mean, this is the PEITHO trial that looked at systemic fibrinolysis in patients that were at intermediate risk. It was a very well done study, I think. It was a randomized, double-blinded study looking at patients getting standard therapy with heparin or heparin and systemic thrombolysis. And they defined the primary outcome as death or hemodynamic collapse, and the safety outcome of major extracranial bleeding or stroke. So, interestingly, as we talked about, there was significant improvement hemodynamically in the patients that received systemic thrombolysis compared to those who just got heparin. But if you look at the all-cause mortality, there wasn't really any statistically significant difference between the two. And if you look at bleeding, whether it's extracranial bleeding, major or minor, there was a statistically significant difference, 6% as opposed to 1%. Pretty remarkable difference. And if you look at stroke, again, another very significantly different outcomes. So again, the benefit, not really much if you look at, hemodynamically, yes, patients get better hemodynamically. But if you look at mortality, not really any difference.
And to your point, it makes the clinician feel better with the initial response. But there are problems down the line, and there's no absolute advantage down the line.
Our treatments aren't supposed to make us feel better. It's supposed to make our patients
That's right.
Better. So how about for patients, anticoagulation? You touched on it earlier. So everybody with a pulmonary, we talked about massive or high-risk pulmonary embolism. We talked a little bit about intermediate or submassive pulmonary embolism. What are the anticoagulation options, and what should be the best option for patients with an intermediate or low-risk pulmonary embolism?
So to begin with, everyone should get parenteral anticoagulation, which is either subcutaneous fractionated heparin versus unfractionated IV heparin. The follow-up to that would be, preferably nowadays, should be the NOACs, or the newer oral anticoagulation agents, apixaban. I don't know all these generic names anymore, but those bands, don't ban them.
That's why we're surgeons.
Don't ban them, use them. But they are the newer anticoagulants that are recommended now.
And I think that certainly historically, unfractionated heparin, so you give IV bolus of heparin and start infusion, that's historically been the go-to drug. The problem with that, as I mentioned earlier, is that oftentimes patients don't get therapeutic right away. So if you're going to use that, you need to be very aggressive in your bolus, in your initial infusion, and in monitoring those patients to get them therapeutic as quickly as possible. Low molecular weight heparin, subcutaneous low molecular weight heparin, I think that many of us consider to be kind of like in a sort of a micro mini sort of mural kind of anticoagulation as opposed to the varsity of unfractionated heparin. But in fact, you do get more anticoagulation right away. And that may be the best go-to drug, or actually I think is considered now to be in patients who have intermediate or low risk PEs.
And it is almost a consensus that this should be the drug of choice, the low molecular weight heparin.
So I'm going to take the benefit of the chair. I'll take all the easy questions, and I'm going to give you all the hard questions.
Okay.
So how about thoughts on low-dose TPA, the MOPET trial with heparin?
So if I'm not wrong, again, I'm rusty on the exact details, but I think the low-dose TPA, which was the 50 milligrams instead of the 100 milligrams lysis.
Of Ataplace, right?
Of Ataplace. And I think the benefit was there to heparin, but there was only short-term benefit with hemodynamic changes. And there was a change, but not significant change to the RV-LV ratio. And so fair game to try, like we are saying. We are not, like I think we're not trying to throw TPA out of the window.
No.
Absolutely not. I think it merits its place with selected patients. At the same time, everyone should not be getting TPA, is I think our point today.
Right. Absolutely. So, and to that point, catheter-directed therapies.
So this is actually one of my cases of a suction thrombectomy from the pulmonary artery. And the way we approach it is usually through the groin, through the femoral vein, where we put in a pretty sizable sheath.
Should I start it?
Yeah, sure. So this is the right common femoral vein axis. This is the dilator that's dilating the tract, because a pretty significantly large amount of material goes through that, which is the 22 French or a 7 millimeter diameter sheath that goes through, actually bigger than that, 8 millimeters. We place it, that's the sheath to go in and out of with the device. And here I'm trying to get, usually we try a catheter and wire combination to get from the inferior vena cava through the right atrium, through the right ventricle, and into the pulmonary artery. Sometimes it's easy. I'm sure this video has been edited because there was some difficulty. So this
looked easy to me.
So this is the pulmonary arteriogram that shows a fair amount of clot in the both upper, middle, and lower lobes, I think. Preferentially this catheter somehow goes into the lower lobe. It just the trajectory, and it bounces off the superior wall or the top part of the pulmonary artery. And we put a wire there, a stiff wire, so that the big aspiration or the suction catheter can go through. This is going into the right lung. These maneuvers are obviously done with a lot of care, because these wires can themselves cause a lot of problems and cause damage to the lung tissue, to the arteries as well. With this catheter in place, there is a dilator, or the inner portion, which is taken out, and now a big syringe is attached to this suction catheter, and a big negative pressure is applied, and we slowly open up. We see a big whoosh of some blood, and usually there is some clot. Here we don't have the first pass didn't show us a lot, but the second and third ones we had a bunch of thrombus out. So the catheter gets pulled back, because sometimes the catheter itself is filled with clot. And so we want, like in this case, if you see there's a bunch of clot that Dr. Lowe, he was a resident, now he's an attending at the Woodlands. He was assisting me in this case. We go on from the right to the left side, and we see a huge amount of clot there. The middle, probably the lower apex and the middle of the lungs not filling at all. Again, the challenge is to get the catheter in the right place. Luckily here we were, I think, pretty successful in doing that. We put in the same catheter on the other side through over a stiff wire and apply the same suction, pull it back again. And with this, I think in this case we were able to get a bunch of clot out from this. And you see a lot of blood there, but when you empty that onto this there, you see a bunch of clot coming out of that. So I mean, and surprisingly, I've seen, so in this case, we still have some residual clot. We went after that again, and we were able to retrieve that. What I look for in these procedures is a filling of the lung architecture. If we see a void, and that void fills in after the clot retrieval, it's pretty good success.
Yeah.
We also measure the pressure in the pulmonary artery on the way in and the way out to make sure that the right ventricle has been offloaded in some way. And we don't really take out all the clot that's there. Very honestly, we're never able to.
Right.
Some of it is stuck to the artery wall, some of it is a little more thicker. And so all we are trying to do is macerate what's there and make it small enough so it doesn't become clinically significant.
So you essentially trying to decrease the amount of right ventricular work that's necessary to allow the blood to get to, through the pulmonary artery to the left side.
Absolutely.
Yeah. So it doesn't have to be perfect. It has to be effective.
Yes, correct. So I think the earlier one we went into the upper lobe and got some more clot out. So that was a demonstration of our.
So we have a question about, and again we can go through all of this when we about training. So how hard is this to train a resident to do? Any tips or tricks to?
There is a learning curve to this process. I mean, this is a catheter that this was placed for. This is a catheter that we do suction thrombectomy with. We don't use lytics in this case.
Yeah.
There are catheters where we drip in thrombolytics overnight into the lung, into the pulmonary arteries. And the challenge in these procedures is to get the catheter into the right and left PA. Sometimes if the right heart is really dilated, this catheter keeps swirling in the heart. So we use a combination of different catheters. Again, the learning curve is there, but I think after a few I still am not the expert on this, nowhere close to being the expert, but about 5 or 10 cases in, I sort of have a methodology.
So you just put a filter in, and we'll talk about filters in a second.
And
so you talked about catheter-directed thrombolytic therapy. So if somebody has a contraindication to systemic thrombolytic therapy, does that mean they have a contraindication to catheter-directed thrombolytic therapy?
So if it's an absolute contraindication to thrombolytics, then I would say even catheter-directed thrombolytics is also equally harmful.
Yeah. So people who have an absolute contraindication to thrombolysis, that have a massive or a intermediate to high risk pulmonary embolism, there are other options. We talked about catheter-directed therapy. There's also surgical pulmonary embolectomy. It's interesting, this is an operation that's a relatively, from a technical point of view, a pretty easy operation.
For you?
Well, compared to a multi-vessel cabbage or
of course.
arch surgery or something, it's a relatively technically straightforward operation. It's just on a very sick patient. And so that, Trendelenburg, and when it first was described, it was done not with the benefit of cardiopulmonary bypass. So I think in the modern world, surgical pulmonary embolectomy is done with cardiopulmonary bypass. So patients are cannulated. I would recommend, usually since you're going to go through a sternotomy, you would centrally cannulate someone with an arterial cannula in the distal ascending aorta. And I would recommend that you use bicaval, 2 separate venous cannulas, one going into the superior vena cava and another going into the inferior vena cava. It can, and I would say, I do this with the heart beating. If you don't stop the heart, then you don't have to worry about starting the heart. And because you're dealing with a compromised right ventricle, arresting the heart, unless you have to, and there are some reasons that you should or might want to do that. So there's what we refer to as clot in transit. Patients who have a pulmonary embolism that are going across some kind of atrial septal communication, whether it's a true atrial septal defect or a patent foramen-ovale. That might be somebody who you should stop the heart with, briefly with cardioplegia, so you can open up the atrium and very carefully and precisely get that clot out and close up the hole. But if you don't have a clot in transit, I would say you're better off doing this with the heart beating on cardiopulmonary bypass. Make an incision in the main pulmonary artery, extending that incision up onto the proximal left pulmonary artery. And from the patient's right side, as you look into the pulmonary artery, you get very good exposure and very good visualization, not only into the left pulmonary artery, but down into the lobar branches. And using, whether it's a sponge forceps or a stone grasping forceps or regular forceps, you can go in and pull out a clot all the way down into the secondary and tertiary branches of the pulmonary artery. To get to the right pulmonary artery from the main pulmonary artery incision is harder, because the aorta ovalize the right pulmonary artery, and you really can't see it. So to do that, what I would recommend is you can take a Wheatland or retractor, put it between the aorta and the mobilized superior vena cava, and then make an incision in the right pulmonary artery just as it is about to go behind the superior vena cava. And just like on the left, this offers excellent visualization down into the right pulmonary artery and the lobar branches, and you can take the clot out. It's quick, it's relatively easy, and just like with the catheter thrombolysis, you can get all of the big clot out. You may not, if somebody has really distal clot and you can't reach it or get to it, another good trick to do is you can have the anesthesiologist ventilate the lung, and you can gently compress the lung, and that pressure will have a push clot out. Or another thing you can do if you've stopped the heart is you can actually take blood from the heart-lung machine and retrograde flush the pulmonary veins to push that out. But that's a very cool thing to do, but I'd say you don't need to do that.
And how often do you find chronic elements, not just acute elements?
So that's a great question, because oftentimes the clot that you get is one of many that either people have had or one of many that somebody will ultimately have. So if you have an acute pulmonary embolism, the clot comes right out. It's not attached to anything. After about a week, that the clot starts to get kind of sticky, it becomes adherent to the wall, and then you have to do a truly formal thromboendarterectomy, which is more of a challenge, and that is hard to do on the beating heart. And the patients can actually start to develop bronchial artery collaterals, and the visualization is not that good. So that becomes a more complicated operation.
No, I asked because we shared a case not too far away, about a month ago, where we were, as the vascular team, was called for a patient with a pretty significant PE. We attempted catheter-directed thrombolysis. She got better hemodynamically, and then one day she just crashed hemodynamically. And you were there. You were, speedy enough to make the decision. You and Mike Reardon operated on this lady, and I was observing you all, because clearly I'm not anywhere qualified to do this procedure. But I was surprised you got her really improved quickly.
Yeah.
And the clot that you took out was not only acute, but had some chronic components with that. And we were talking about doing a thrombectomy on somebody who has got lytics in the past, and you said taking that clot out is like squeezing on toothpaste.
Right.
It's really hard.
So the clot itself starts to degenerate in terms of its integrity, but it also starts to stick to the wall. So it's the worst of both worlds. And you can get this is a real picture of a big clot I pulled out of a pulmonary artery a little bit of time ago.
And this is like a classic cast of the femoral vein.
Right.
That is just shot up and just snagged into the arteries. It is impressive.
So not everybody needs to get a surgical pulmonary embolectomy, but those patients who are have contraindications to thrombolytic therapy, patients who are actively bleeding, because sure, you need heparin for cardiopulmonary bypass, but you can give the heparin and then you reverse the heparin. So if somebody's bleeding, paradoxically, that would be an indication for a pulmonary embolectomy as opposed to thrombolysis.
And then how critical is it to maintain anticoagulation after an open pulmonary thrombectomy or embolectomy as we have a patient who might be having some ongoing bleeding?
So it's not for what you did, it's not for the clot you took out or for anything you did surgically. It's to prevent and treat them for potentially the next pulmonary embolism that they may have in the post-operative period, which is why we would recommend, unless there's a contraindication, to long-term anticoagulation and putting a filter in.
Yes.
So patients who are crashing, if you're in the emergency room or in the ICU and somebody is getting CPR or somebody is getting, is just in hemodynamically very unstable, I think in this day and age, rather than trying to rush that person getting CPR down to the operating room for pulmonary embolectomy, putting them, cannulating them at the bedside for VA or veno-arterial ECMO is the right move. And it's a good, unlike you don't want to do a pulmonary embolectomy on somebody who got systemic thrombolysis, because the bleeding will be torrential and hard to control and life-threatening. You can put that person on VA ECMO at the bedside, maintain good cardiopulmonary function. You can reestablish the blood flow and the blood pressure and gas exchange. And many times, just being on VA ECMO and being anticoagulated, that massive or submassive PE will become much smaller or go away. Or once you get end organ function better, you can take them to the operating room for a pulmonary embolectomy or to the hybrid room for catheter-directed therapy. Filters. Charu, you're on.
Don't do them. Well, I mean,
it's a double-edged sword, right? IVC filters?
Yeah, it's more like an umbrella. But I mean, this is a question that we always get asked, and I think it's very valid to keep answering this question again and again, because evidence has changed, and we know for a fact that not everyone needs a filter, because mostly people can get anticoagulated.
Right.
So the recommendation is anybody who gets a DVT or a PE being on anticoagulation at that time will need a filter, because clearly they have a failure of anticoagulation.
Yeah.
Anyone who has a complication of anticoagulation, for example, a gastrointestinal bleed or a brain bleed, should get a filter because they are no longer able to get anticoagulated. Anybody with, I think the example is somebody who cannot get anticoagulation but has a massive PE who's undergone a pulmonary embolectomy should also get an IVC filter. So inability to get anticoagulation. But otherwise, if you can anticoagulate them effectively, then that should be the treatment of choice.
Yeah. So I mean, there was a time, certainly 20 years ago, the medical community was very liberal in the recommendation for the use of filters. Is that right?
That is correct. And we are seeing those downstream effects currently. You know, the interesting portion is the inferior vena cava is not a rigid pipe. It is an organ that moves when we breathe. It's an organ, it moves when we move. So it gets compressed from side to side, from front to back. And this filter is made up of stainless steel or titanium or whatever material is made up of, or nitinol as they call it, and that expands. But this does get some certain wear and tear. And metal versus tissue loses the battle mostly. So these filters can either break or they cause holes in the vena cava, they can protrude out of the vena cava, etc. We've had a fair amount of patients that have needed open surgical procedures to take these filters out, and there's no way a benign procedure to do.
So you are very adept at putting in IVC filters. Do you always put in a retrievable filter now?
So current standard of care is always put in a retrievable filter. That is correct.
And then based on the previous standard of care, which were non-retrievable filters, you've also become quite adept at taking those non-retrievable filters out as well.
Yes, with some sweat, for sure.
Yeah, they're hard to get out.
Yes. So one point is the instructions for use, or IFU for devices for filters, typically within a year of placement should be taken out.
Yeah.
Is the thought.
So not the topic of tonight, but CTEF. What is CTEF?
So certainly something that I think is a consequence of having PE. Not everyone gets it,
Yeah.
but a lot of people are at risk. So chronic thromboembolic pulmonary hypertension, which is chronic hypertension in the pulmonary vasculature because of pre-existing clot, which is now organized and thickened and cause the arteries to probably shrink down.
Yeah, so the conventional, the classic teaching is, if you had a pulmonary embolism and you didn't die from it, that over time your body would resorb all of that thrombus and you'd get better. And I think in large part, or certainly in most patients, that is true.
Very true.
But not all patients. And that not all patients will reabsorb the clot. And in fact, not only will they not necessarily always reabsorb it, they can get more and they will develop laminated thrombus and chronic obstructive disease in their pulmonary arteries that will lead to pulmonary hypertension.
Right.
And there is a very effective therapy for that now with a pulmonary thromboendarterectomy, which is as opposed to an embolectomy where you go in, you take the acute clot out, you go in with cardiopulmonary bypass and actually require circulatory arrest to stop the heart with the patient very cold, because again you get these collateral blood vessels that develop that you can't see because of all the blood. That would be a very good topic for a CV Live on another night.
Totally.
We talked a little bit about PERT teams, and you want to talk about that, Charu? What is a PERT team?
So the pulmonary embolism response and treatment team, and we touched upon this in the beginning, is how critical it is to get a PE patient treated timely, correctly, effectively, and followed up after all that treatment. PE is something that, I was talking to one of our cardiology colleagues and he mentioned just in passing that this is an orphan disease, which is true. It really has no single specialty that owns it.
Right.
But everyone is involved in treating it, so then why not bring everyone together if it can effectively treat somebody? The flip side is, this is not something that is incentivized. We do it from our own goodwill to treat this patient correctly.
So when you say multiple specialties, we're talking emergency medicine, imagers, vascular surgeons, cardiothoracic surgeons, hematologists, pulmonologists, cardiologists. There is and because many patients with different kinds of malignancies prone to developing DVTs and PEs, many PERT teams have oncologists.
Yes,
I guess
course.
part of it that are part of the team. So misery loves company, or as we say at CV DeBakey CV Live, don't learn alone.
Yes, absolutely.
Get everybody involved for the benefit of the patient.
Yes.
And that's not something to be used as an after action event. It's something that PERT team is. It's like activating the cath lab for an acute coronary syndrome, or activating the hybrid suite of the operating room for somebody with a acute aortic dissection. This is an event that's life-threatening, and if you have the right people at the patient's bedside, you can make a big difference.
Absolutely, absolutely. And it has to be taken with a pinch of salt, because the PERT team is somebody who can help guide. It's not the team that actually would drive the treatment, but the team will help channel the patient the right way and ensure that we have a follow-up on this. So I think there was a question on the poll how far are we in doing the PERT team. We are infinitesimally close, I would say.
Yeah.
I think you and I probably have the reins in our hand, We have a good bunch of, the ER docs, the intensivists, pulmonologists together, and everyone's on board. So we are very, very close to answer that question.
We have, I can proudly boast that we have really taken the benefit of our expertise as a PERT team and helped a lot of patients with very significant pulmonary emboli.
Absolutely.
It's very gratifying to be able to do that.
Absolutely.
Well, Charu, we're at the end of the hour. I've certainly learned a lot from you. It's been a great discussion. I want to thank everybody for tuning in to DeBakey CV Live, and we look forward to more broadcasts and being able to broadcast to you some of the very exciting and intriguing topics here, and we'd be very welcome to any suggestions that you have for topics you'd like us to discuss. With that, good night, and please stay well and stay safe for you and your families.
Good night. Thank you.
Good night. Thank you.